roasting the experts. That means you must ask questions which will bring out the best in them. There will be no introduction because all are legends, and there is trying to introduce legends like Professor B. Mohan on the top of the world, by Professor Fernando, nephrologist of repute, and of course SNN is just showing, is just trying to do something which is not necessary. We'll save that time. There'll be no formal introduction. And we have two rounds of questions. We have 55 minutes. So we'll be leaving behind 10 minutes for yours to ask questions. It's an extempo session, so it is totally what they feel. I will start with Professor Mohan. There are many contributions he has given to the world and to our nation. I'll confine myself in the beginning to two. One is his contribution as the Asian phenotype of type 2 diabetes. Mohan will speak about it.
Okay. Thank you, Ashok. So we know that as far as type, I spoke about it in the other hall also a few minutes ago. So as far as we are concerned, generally we associate type 2 diabetes with obesity, and that too with severe obesity. So if you sit in a clinic in the US and somebody comes in with type 2 diabetes, invariably they're obese. 95 to close to 100% will be big made people, and the obesity is huge. Whereas we tend to get type 2 diabetes at much smaller BMI. Of course, we do have very obese people, but that's a much smaller number. Then we have people who are type 2 diabetes or of normal weight, and indeed even underweight. So you can have somebody with 18.5 BMI, 18 BMI, who also has type 2 diabetes, not type 1. It is not type 5, it is not malnutrition, it's not type 1. Classical type 2, they respond to tablets, they still have C-peptide and so on. So that's one thing. Then we have the classical, what is called as the TOFI, thin outside, fat inside. So we are called as thin fat Indians because we look thin, but you measure the fat, MASLD, you will have a lot of, you do a DEXA scan, you will find a lot of fat, intra-abdominal fat, visceral fat, liver fat, all that will be there. So we look thin, but we have a lot of fat. Now, whether that is due to genetic factors or whether it's due to environmental factors, is it due to the rice that we are eating in South India, or is because we don't do exercise? I think it's a combination of everything. So, of course, carbs play a very big role, as we saw in the INDIAB and other studies, but it's also because we don't do enough exercise. But beyond all that, there seems to be some kind of a genetic predisposition. When we looked at the genes in the South Asians in the UK and here and compared them with the white population, we seem to have more of the genes for beta cell dysfunction. So we have an enrichment of those genes. Therefore, we seem to get beta cell failure early, and that's the reason why our lean people get diabetes. Of course, apart from that, we have low adiponectin levels, we have high CRP levels, we have very low HDL levels, we have triglycerides are very high. There are many, many reasons. We seem to start with hyperinsulinemia, but it doesn't last, and very quickly it goes off. Of course, my friend Dr. Yajnik will say it's all due to B12 deficiency. Maybe partly true, but it's a multiple factors which are contributing to that. We are also very much prone to heart disease. So if you take premature heart disease, when I worked in the UK many years ago and looked at the heart attacks below 40 years at the Hammersmith Hospital, that leading teaching institution there, now Imperial College, we found that there was not one single white man below 40 years, not even one. This is in the UK. Not one man below 40 years had heart attack. Of all the heart attack below 40 years, 70% were South Asian, 30% are Afro-Caribbean. There's not a single man. It cannot be as dramatic as that. So the same thing makes us more prone to MASLD. See, the hepatologist will talk about MASLD. We talk about diabetes and insulin resistant. And Dr. Narasingan will talk about dyslipidemia and something. The cardiologist will talk about premature heart disease. I think we're all addressing the same thing in different ways.
I think brilliant answer, Mohan. So what it calls for is early screening, early diagnosis, and maybe more intensive treatment to start with. I mean, because they're more prone for this. Now, would you say that they need? Of course, you spoke in the other hall about these clusters and how the precision type 2 diabetes management revolves. There are two halls. We can be in two places at the same time. So, Mohan, just gist of what you mean by precision type 2 diabetes on the 5 varieties. Very brief answer.
So it's actually four. The fifth one
Four.
is the severe autoimmune diabetes described in Scandinavia. That's more like a type 1 or a LADA. So we don't bring it into type 2. But you have the severe insulin deficient type, the SIDD, the insulin resistant obese diabetic, the IROD, the combined variety, the CIRDD, and the mild age related one, which is MARD. So as a person walks in itself, obese person comes, it's IROD. If you do the HDL and triglyceride and find it's very high, it's CIRDD. But if a very thin young person comes, it is SID only. And an older person, 60 years, 75 years, comes and says, I got it last week, it has to be MARD only. So even by looking at the patient, we can do that. But by doing simple biochemical tests, BMI, HbA1c, weight, with simple age, you can make a diagnosis. It is useful because the insulin resistance has to be treated with the sensitizers, obviously. Insulin secretory defect, beta cell dysfunction, has to be with secretagogues. And the combined variety probably needs both. And the mild age-related one probably just needs metformin, little diet, and they'll respond well. So this is the basis of precision medicine. So when you talk about precision medicine, classifying into different types, type 1, type 2, type 5, and GDM, and FCPD, and all the types, and monogenic, MODI, and so on. Within type 2 itself, don't think they're all the same. You have to further subclassify because this has therapeutic. As for example, a very thin person, you're not going to restrict his calories very much. Whereas a very obese person, weight loss becomes the top thing. So you'll probably consider a GLP or a combination of GLP and SGLT2 for that person. Because weight loss is the most important parameter for that particular person.
Great. I think, Mohan, the last question in this segment is a very brief answer, Mohan, because we have two more people too. Now, the first thing that I'll ask you, type 2 diabetes in the young. We have called it quote-unquote malignant diabetes. What should be our approach in treating them?
Type 2 diabetes in the young
is
a little bit more severe form because they must have had a stronger genetic factors and they must have had obesity. Otherwise, they won't get it at a young age. Study after study has shown that if you look at retinopathy rates, heart disease rates, and everything in those who get it at the young age, it's much more difficult to treat them at that young age. So as he said, we call it as malignant type of type 2 diabetes or more fulminant type. We use different names. But you have to be very aggressive. If you just give them on metformin and all, they won't respond. You have to hit them with 2-3 drugs starting itself. The older person doesn't need that aggressive treatment because also remember, not only they have more severe, they have to live with it for a long time. Somebody gets at 20, even if you're talking about 70 years of age, it's still 50 years of diabetes. Whereas you get it at 60, you're planning for 10, 15, 20 years, not 50 years. So that you must keep in mind. And the first 10 years are very important. UKPDS, DCCT showed us that. Legacy effect, good metabolic memory. So first 10 years, if you control well, next 10 to 20 years, you're protected.
Good. I think, Mohan, I'll come back to the second round of questions. Now, Professor SNN is an authority on many things. But two things I've taken up for today's discussion. One, the lipid, which is his absolutely own territory, and of course, hypertension. Now, what do you think about the current guideline that you have given, Raman has given, many people, and how many of Indian population achieve those numbers, about 70, 56 or whatever, lipid numbers?
Oh, this is a very big question. Probably I don't know whether it will be in a position to cover
just
everything.
The gist of it.
I think the European Society of Cardiology had come out with the recommendation that you need to keep the levels less than 100 for everyone in general population.
Yes, exactly.
If somebody has one risk factor, including people with diabetes, keep the levels less than 70. The same thing is true even for our Indian population, and we also had come out with the same recommendation.
Correct.
That for general population less than 100, for people with diabetes less than 70. People who have already developed an event in the form of an ACS or in the form of a stroke, they are expected to keep the levels less than 50 milligram. In fact, which we popularized way back 2016. Only in 2019, the European Society of Cardiology came out with the recommendation that it should be less than 55 based on evidence. And we also had come out with a recommendation prior to these people. And we also came out with some recommendation because of the evidence which was available during that time. And in case the patient gets recurrence of attacks, for example, stroke patient getting a heart attack, or a polyvascular disease, which you commonly see even in people with diabetes, you need to keep the levels less than 30 milligram, because we have introduced a category called extreme risk group B category, where you are expected to keep the levels less than 30. Do you have evidence? Yes, we have lots and lots of evidence. If you allow me to talk, probably I can
No, I
present
think
any
it will
number.
be difficult, but tell me, in how many percentage of cases are we achieving that number?
Keeping this sort of goal for patients, I think most of them are now trying to, uh,
Correct.
most of them are coming to the levels of less than 70 milligram. Less than 70 milligram, but very difficult to reach the levels of 50 milligram.
Correct.
But when you are using a combination of lipid lowering drugs, because that is a trend now which need to be addressed to almost all the gatherings,
Yeah.
including physicians or general practitioners or the specialists, that we need to combine the drugs rather than giving only a high dose statin.
Correct.
So statin moderate dose or a tolerable dose, plus add an acetamide, which is very important, neglected one. I think that is the best combination to be given to patients with diabetes, because that will help those patients with the polyvascular disease. In addition, if the patient is not bringing down the LDL cholesterol with these two therapies, there is a good option to use either a PCSK9 inhibitor or the inclisiran, which is a small interfering RNA drug. So if these drugs are used, definitely I am getting my patients well below
Good.
this line.
Very good.
Even
Very well
30,
said.
20, even 15 milligrams also.
Yeah. I think, SNN, the question is regarding the comparison between the LDL lowering and TG lowering in Indian population. Do you have any comment on that? And do you believe that only 500 we should start treating, or in Indian population we should start treating at a little level, say about 250
I know
or
why you
whatever?
are raising this particular question, because as Indians we have an increased levels of triglycerides,
Exactly.
lower levels of HDL.
You see,
but you need to think that there are two more components which need to be addressed in this. One is a small dense LDL cholesterol, which we don't measure.
Correct.
We always depend on the triglyceride for the small LDL cholesterol. In addition, think about the ApoB, because ApoB 100 is the one that is seen in almost all the atherogenic particles. Atherogenic particles are dominated only by the ApoB 100. So if you are going to concentrate on that, if you are bringing it down, that is the best way of lipid lowering. As a recent publication last week, only ApoB 100, we need to move away from LDL cholesterol. In our population, when the triglycerides are raised, you need to think that the patient's, what about his lifestyle, whether he is consuming a lot of carbohydrate,
Yes.
alcohol ingestion, or obese person, or overweight person, or he's got a secondary hypertriglyceridemia, maybe due to hypothyroidism,
Yeah.
or is it due to nephrotic syndrome, or something. These are the things which need to be evaluated and excluded. After that, if you see that the triglycerides are still elevated, after excluding all these causes, you think that it is requiring some sort of intervention. I think in our population, between 150 to 499, you try to keep that as a category for whom you can always prescribe a drug called icosapent ester, which has shown a good amount of remarkable
Exactly.
achievement in the primary endpoint by 25% and secondary endpoint by 26% in reduced trial. So this is the drug which should be used in those patients with diabetes, in those patients with diabetes with a high cardiovascular risk, or established ASCVD patients, or in those patients in whom you have already reached the LDL goal of 70 milligram and less than that, and the triglycerides are high, put them on icosapent ester. Between 500 and above, you need to use the fibrate. I think the fibrate need to be given a priority
Correct.
only for that particular thing, because having seen the reports of fibrate usage in the last 5 decades or so, we are still not having our own hesitation to keep it under this category of recommendation.
Correct. I think SNN, I want to ask you one more very important question. Is the fact that the lipid lowering drugs are available, and available at a very, I think it's affordable price. Now, I do not know why our clinicians don't emphasize that the lipid lowering drugs has cut down heart attack by at least 1/3, so many benefits. But I find many people are defaulters in the statins. It is our fault, or what do you think?
I think the physician's inertia to start the drug, physician's inertia to increase the dose of the drugs, physician's inertia to give a combination of drugs. Physician has to talk to the patient. For the patient-physician interaction is much more important. When a patient seeks advice for diabetes, you should not stop only with the anti-hyperglycemic drugs. You should always try to put the patient on a statin. Whether the LDL is normal or abnormal doesn't matter. Put the patient on statin because that is a newer trend for our approach in managing.
And what's your advice beyond liquid fluid therapy and beyond exercise for the HDL increase?
HDL increase, I think you have already highlighted that it is the exercise that is important, no doubt. It is still one of the important measures which you can always advise our patient to do. Regular physical activity will increase the HDL. Within a matter of 2 to 3 years, you need to have an exercise. Only then the HDL will go up. Increasing the HDL by pharmacotherapeutics have failed to show.
Absolutely.
None of the trials have shown any sort of benefit in cardiovascular outcome by using CETP inhibitors or the niacin drug. All those things have failed. In fact, 120 milligrams of HDL, but there is no benefit at all in cardiovascular outcome.
Good.
Only one drug that has now probably been introduced in the United States is obicetrapib. Obicetrapib is a cholesterol ester transfer protein inhibitor. This particular drug has not only reduced the LDL, but also increased the HDL, and the cardiovascular outcome data is also encouraging.
Great. I think absolutely fabulous answers and clears many of our diets, gives us new information. I'll come to Professor Fernando. I think the question I want to start with, do you think that today we should also care for the non-albuminuric DKD?
Yes. To begin with, CKD is emerging. It's already a global health issue.
Absolutely.
And it is emerging even more worse. In 2013, CKD was the 17th common cause of death. And in 2040, it is predicted to become the 5th common cause of death. So CKD comes along not only with kidney disease, it comes along with heart disease.
Absolutely. Because the CKD is the fertile soil on
Yes.
which heart attacks occur. Absolutely correct.
So this is number one. Number two, the world literature shows that non-albuminuric diabetic kidney disease is nearly about 40 to 50%. And we find this, many of our patients also have this. Though the classical diabetic nephropathy comes with edema, proteinuria, hypertension, and worsening creatinine. However, we have a sizable number of patients who have minimal proteinuria, who have kidneys that are small or normal size. Generally, a diabetic kidneys are quite large, even in end stage, they're quite large. And we have hypertension. We have patients who have recurrent episodes of pyelonephritis, scarring of the kidney, drugs used in the treatment of pyelonephritis that could probably cause some interstitial nephritis, and repeated episodes of acute kidney injury happening in diabetics. All this contribute to non-albuminuric.
I think, Dr.
diabetic
Fernando,
kidney
one question
disease.
here. I'm just jumping because I have to finish and then we have 10 minutes for the people to interact with you. Sir, I want to ask you, Dr. Fernando, is the fact that if you do not take recourse to UCAR or albumin excretion, is it only the EGFR and the imaging, or how do you catch these people? This population of non-albumin CKD, you do catch them by EGFR and imaging or any other way, any other marker to catch them
No,
early?
unfortunately, no. Unfortunately, no. So we have to look at only the urine examination. Of course, in a diabetic, we always follow both together, UACR as well as the EGFR, the slope of EGFR. Both are very important. But when you have somebody whose GFR slope is going down and still the proteinuria is not that very high, that is the population that we are probably tracking.
I think, Dr. Fernando, the people, the nation wants to know from you is that today we have got 4 pillars of DKD treatment.
Yes.
I mean, I should not narrate them, but there is little bit of, no clarity on the role of finrenon, the non-steroidal MRA, and also whether SGLT2 come much earlier, can it replace metformin? Third is, it has been said GLP-1 RA is already evidences is there for the heart, but for the kidney they say the evidence is still emerging.
Yes.
So would you like to give the correct perspective of these 4 pillars?
Yes. So the time-tested molecule is the RAS inhibition.
Absolutely.
With either ACE or ARBs, either one of them.
Yeah.
The number 2 is SGLT2 inhibitor. Of course, if you take glycemic control, the KDIGO guidelines.
How much this RAS uses is responsible for the non-albinuric decay?
Again, it is not very clear whether RAS would help in such a situation. Yeah, it's unlikely.
Yeah.
So RAS inhibition is one. Number 2 is SGLT2 inhibition. As far as glycemic control is concerned, KDIGO still recommends a combination of metformin and SGLT2 to start with. Number 3, of course, will be to add non-steroidal MRA, as evidenced by the Figaro and the Fidelio DKD studies. It has been shown beyond doubt that both these are important. If the GFR is more than 25, it could be used. Of course, one has to watch for hyperkalemia. It is said that an SGLT2 would probably balance the hyperkalemia with NSMRA. So some amount of potassium loss could be there with an SGLT2 inhibitor.
What has been your experience of using Finrenon at about 20 eGFR or around that?
No, it is recommended only for
25.
about 25.
Okay, so you don't
As
do
of now, it is only there. It has also been found useful in the other non-diabetic CKD also. The
Yes.
FIND CKD trial that has been recently published has found its usefulness. Regarding the GLP-1RA, there's been the FLOW trial that has shown some evidence, though as a nephrologist, I'm not really clear how it really
Yeah, it is not compared to select trial. correct.
effectively, what is the mechanism by which this improvement in kidney function is brought about. However, there is evidence now, and we include the GLP-1RA also in our armamentarium. So the ideal combination would be to use RAS inhibition, SGLT2, and a non-steroidal MRA.
Yeah.
GLP-1, again, we have to choose the right patient for GLP-1RA.
Yeah, I think as you rightly said in the beginning, and Mohan and SNL will agree, the kidney part of the diabetic complications is rising more and more. I'm really worried the number of patients that we see, and as rightly you pointed out, the dialysis or renal replacement of any type, the diabetics are at the maximum number. So, what will you advise for the preventive measures of keeping the DKD away, either totally prevention or postponing for a very late date?
It all depends on the family history. I would
Family
think,
history of hypertension,
yes.
family history of DKD.
Diabetes,
Any other
yeah.
family history?
So these are the ones.
These two. Achha.
The other thing is, in any generally CKD, it is not that all of us have 1 million nephrons in each kidney. We are born with X number of nephrons. Barry Brenner, the very famous nephrologist, mentions that all of us are endowed with a X number of nephrons. This may not be uniform in everyone. And if you take the development of the nephrons, at birth, the number of nephrons that we have is the number of nephrons we have to live with for the entire life. And when you take the nephron development, the last trimester is when 60% of the nephrons develop.
Come on.
Right? The kidneys start making urine by 9th week of intrauterine life. But the nephron number is maximized at the 3rd trimester
So,
of
Fernando,
pregnancy.
do you mean to say that our measures should start in the intrauterine?
Exactly, that's what I
life?
was trying to say, primordial prevention.
Yes, primordial.
So ultimately, we need to have good antenatal care, good healthy babies born at term, so that the babies get the maximum number of nephrons. So suppose we have a pre-eclamptic mother.
So how do you do it? Mohan has written extensively along with his Australian colleagues about the early GDM. Maybe that's one of the way of catching them early, catching them young. What other measures you suggest? This is something new. I think we knew that the good antenatal care is absolutely paramount.
Unfortunately, with late pregnancies now, with women going for careers and late pregnancies, infertilities, we have more patients coming in with preeclampsia.
Okay.
So preeclampsia. So when you have somebody with preeclampsia and there's an obstetric indication to terminate the pregnancy at 7th month, you're going to have a baby that is small for that particular age, 1.8, 1.7 kilos, and with a lesser nephron endowment, which ultimately leads to CKD many, many years later.
Thank
So
you.
I think our prevention should be primordial rather
The
than
Mohan wants
reactive.
to
Can I
summarize.
ask
Yes, Mohan, please.
Edwin a question?
Yeah, that's the
So,
beauty of it.
yeah. So, is there any evidence that the incidence of CKD is higher in kidney donors? Because they've already lost 50%.
Yes.
The reason I ask is I've seen some people who wanted to give for their mother and they actually gave the kidney. And then at that time, everything possible we did to see that they will not develop diabetes and so on. But eventually,
Yes, sir.
about 10, 15 years later, their EGFR is also going down and their creatinine is going up. They're developing diabetes. Is there any systematic studies done on that?
Yes, sir. We ourselves have looked into our data of donors. We have really scaled. We have about nearly 1,000 transplanted, all our related donors. So we have them on a regular follow-up. At least in our cohort, we have not lost any patient because of a kidney donation, number one. Somebody died during lightning and somebody died during tsunami.
Thank you.
Yes, sir. We looked into it, and also studies by people, long-term studies, people looked into 40-year-old follow-up of donors. They did not find any proteinuria or hypertension or a GFR decrease compared to the general population. It was not that very significant. However, if there is a kidney donor and if he develops a Goodpasture syndrome or a vasculitis or an acute kidney injury, then that's going to be very detrimental. But of course, what we tell all our donors and what we do is, if you have donated a kidney, of course, at donation, we make sure that everything is fine. And these are people whom we keep on a regular follow-up. So we tell them annually you have to check your sugar, your albumin, and your creatinine. And we tell them do it on their birthday month. So that's the best way to remember, because annually is sometimes, it keeps postponing.
Yeah.
So we tell them on your birthday month, make sure you check all this. This question is, actually there are a lot of people who have raised concerns about live kidney donation, and disease donor program has picked up very largely in our state. We are the leaders, like many other fields, we are the leaders in disease donor transplant
I want
in
to
Tamil
ask you
Nadu.
one thing. The vegetarian diet vis-a-vis NV diet. We have less time, so very focused answer, Dr. Fernando.
Correct.
The
Plant-based
plant-based
protein diet is
and-
definitely
and
recommended,
the
sir.
non-veg diet, how does it impact diabetic kidney disease for prevention and once it has occurred?
I'm not sure about diabetes, sir, but generally in CKD, this is called the PLADO diet, the plant-based vegetarian diet.
Protein is background.
Yes, definitely has advantages and has postponed CKD.
Yes, yes. I think. Thank you. We'll come back to you again the last question. Mohan, I have to ask you something very, very important. ICMR in DAV has made a ripple in our country and also abroad. Now, in this particular study, we had many lesions, but in a brief time, Mohan, because we have to finish by 2:10. By any time, means we'll finish by 2:10. So, can you tell us the learnings from the ICMR in DAV study, which we have published now? We have numbered it in the 1 to 23, whatever. So, what are the learnings?
First of all, the very high prevalence of diabetes in some states as compared to others. So there's a lot of heterogeneity. It varies from 4% prevalence in Uttar Pradesh to 26% prevalence in Puducherry, your state, and Kerala and Goa. That's the first thing. Second is
And what it is due to, Mohan?
it's predominantly due to socioeconomic development, because that's related to obesity. It's also due to longer lifespan in Kerala. So many factors, but obesity is a big driving factor. Third is that pre-diabetes prevalence is high everywhere. So even in the places where diabetes prevalence is low, pre-diabetes is high, showing that the epidemic is going to continue for a long time. Fourth, we now have data on kidney disease from the whole country. And there again, there are regional variations. Some part, I don't know, is it due to the Telangana belt being more, but Telangana definitely had higher. So we were able to map that as well.
They used to have that unknown factors, no?
Unknown CKD. Of
Uddanam,
unknown
Uddanam
origin.
nephro. There's an area called Uddanam,
Yeah.
Yeah, exactly.
just below Odisha,
Yeah.
where villages of people have been affected
Having
with
kidney
CKD.
failure.
It's called CKD-U.
Unknown etiology. Unknown etiology. So we picked that up also in the thing. We also had data on the interesting part in relation to GLPs and so on, is that we had this non-obese, metabolically obese, so monotype, metabolically obese, non-obese group, where the BMI is below 23, but they had waist being increased and triglyceride being increased. That is a typical that thin fat Indian thing. So that's 43% of all Indians have that. 43%, almost half of India has that. And that's there even in rural areas.
Even MO is about 28.
Yes. So the metabolically obese also is high. If you add these two, it's more than 73%. So that we cannot say that there's no obesity in India. The other thing that we found is in relation to diet, cholesterol levels definitely correlating with the oil intake. For example, in Kerala, the mean LDL and mean cholesterol level is about 30 milligrams higher than Tamil Nadu. Now, despite that, longevity is not affected there. Doesn't mean that LDL, because they also have other things. They have better education, nutrition, they eat fish, they eat many protective things they have. They exercise, walk more and all that. So, but definitely we're able to see in Goa and in Kerala, LDL level is very high. In Punjab, where a lot of ghee and butter is eaten, it is very high. So we're able to track the differences in urban, rural, state-wise, men and women, age-wise, obesity, hypertension, dyslipidemia, all these things. It's like you can keep on, it's like taking gold out of a gold mine. You can keep on taking, more and more seems to be. You only have to, the GDM, that's how it came out. We suddenly realized, we also studied pregnant women. We didn't leave, it was not meant to be a GDM study at all. But we said, how many pregnant women came? It was a few thousand. So we said, it was 120,000 totally. So then we found some came in first trimester, some came in second trimester, then 24, 28 weeks. I said, just look at the glucose level. You get the GDM prevalence. Imagine doing GDM prevalence in an epidemiological study in the whole country. It'll be mind-boggling. You cannot do it. But we got that also. So like this, newer things we are thinking of and we are getting.
And one question, I know it is the duty of everybody in the country to do that. Policy. So policy, the gap between the data that you have generated, absolutely fabulous data, and the actionables. So what is in your mind?
So we've already done it, not only in our mind. So we found that even a 10% decrease in carbs and a 10% increase in protein can have a tremendous effect in preventing diabetes. So about 2 months ago, we went to Tamil Nadu government. We met CM and we met Kanimari and we met all of them, all the IAS officers, and said, all you have to do is change the PDS thing. They are giving 25 kilograms of rice and giving 1 kilogram of dal. We said, why don't you give 2 more kilograms of dal and reduce one for rice. Our election we should not have rice. I said, okay, then don't reduce, just give little more dal. So they have accepted it. The government has put it into their thing and they said we have to find budget for it. So they said if you come back to power now, they will definitely include it. They've included it. They're convinced about it. The data is very... What we did was we said how many cases of diabetes will prevent, how many kidney cases therefore you will prevent, how much you will save, how much the government will save. When you worked it out, just giving a little, of course it's expensive. To give dal is very expensive. When they are giving it to crores of people. So when you give that dal, lot of the budget goes up by many, many crores. So the government has to budget for that. But it's still worth it. It still helps to, one of the simplest things that we can do. So we have told them, just increase physical activity of people, reduce rice, give more dal. That's enough. That's a simple thing that you can do. The government is very convinced about it. The national government also, we are working on it. We have spoken to Dr. Vinod Paul. He is very convinced about our Nature Medicine paper.
The chief of the Niti Ayog.
Niti Ayog. Yeah, that also. Because that also, they're saying it's politically sensitive. When you say no sugar, election coming. But they have recorded it. They said science part of it, because we worked with MS Swaminathan, with Soumya Swaminathan. And we did a complete study. What will be the benefit? How many people will benefit? We wanted, because Karnataka is already doing it. So we said, now Tamil Nadu can say, already one state is doing it, let us do it. Once that is a success, then in other states we can do it.
Good. I think great. Yeah, absolutely.
In
We will
continuation,
not talk more about it now. We will not talk more about it now. Sensitive issue. After May 4th.
I think they should also stop giving palm oil in oil.
No, that we have told. We already told.
Yeah, that's very, very
Again, groundnut oil is the one which we have found to be best. The cost is 2 to 3 times higher. So we can do that. Palm oil, actually, we are importing palm oil. They have convinced about. So in the program, we said increase dal, decrease rice, decrease sugar, and change palm oil to groundnut oil. All the four we have said. They've accepted in principle. The science part of it, they accepted. How they find the finance for it.
Implementation will take time and also labor intensive, cost intensive. Yeah, absolutely. I agree with you. Now,
So in continuation of the
please,
diet,
please. Please.
when we looked into our dialysis mortality, we found most of them are dying because of malnutrition. So when we took this to our government again, so the government started giving, we recommended that all our dialysis patients in all the government hospitals of the state get 100 ml of milk, 100 grams of channa, 3 protein biscuits, and 2 eggs whenever they come for dialysis.
Wow,
So this we have implemented from last May.
Great. I think
Tamil Nadu government is to be admired.
Whatever recommendation that Dr. Mohan has given to the government, I think the same government should come to power now.
I think Narasimhan, we're treading into something different. I would like to ask you one.
One good thing about Tamil Nadu government, whichever government comes, the schemes continue. Unlike other states.
Exactly. That's the beauty of it. SNN, I want to ask you about hypertension. How many types of hypertension you encounter in diabetics? I'm not taking
The
MD
percentage of people who are seeing with hypertension association with diabetes.
We
I
had
think-
in the ISO India 35%.
Now, more than
More
60,
than
60 to
60%.
65%.
Double general population. The general population. So it is 60. It's
60
just the double general population.
Yeah. At least in one's lifetime in a diabetic, I think he will encounter problems of hypertension.
Absolutely.
think his question was
Types.
hypertension or secondary hypertension.
Or diabetic kidney disease induced hypertension. And also some people have said that there is a diabetes specific artery disease which can produce hypertension. Your comments on that? A small vessel.
Yeah. It is possible to get into some sort of categories like this of hypertension.
Correct.
But as a clinician, you need to see whether he has got a coexisting cardiovascular risk factors like diabetes or dyslipidemia with hypertension. So even lipid tension, yesterday you were mentioning
Yeah, I
about
wait
lipid
this.
tension.
We have
Hypertension with the
hyperlipidemia.
dyslipidemia, you call that
It's
as a
called
lipid
lipid tension.
or
And
dyslipidemic hypertension. The terminologies are like that only. I think you need to concentrate on those issues rather than talking about the micro
And what is,
changes.
okay, I get your point. What is the drug of choice and what numbers you want to maintain in diabetes in general? I'll come to Fernando later. What level in diabetic kidney disease? But what in diabetes, what is the number systolic and diastolic you like to maintain?
Yeah. In fact, that's a good question because universally many guidelines have adopted this one. Based on the evidence now, 130, less than 130 systolic, less than 80 diastolic is the correct number that
Absolutely.
you should keep in mind with all those patients with the diabetes. Almost all conditions, right from your problems of increased risk, less risk, diabetic, non-diabetic, CKD, whatever is the criteria that you are going to give it to us, all those people who suffer from all these conditions need to keep their levels less than 130 or 80, recommended by 2017 ACC-AHA guidelines, which we also had popularized through Indian Society of Hypertension. So 130, 80 you should keep in mind. But there are good number of studies which have recently been published. One is the aspirin trial, other one is the BP road trial, which was conducted only in people with the diabetes. Because they wanted to disprove that the Accord trial, which had evaluated people with hypertension, less than 120 caused more injurious problems, including mortality benefit was not seen. Whereas they wanted to bring down the blood pressure less than 130, less than 130, 120 to 129, excellent. That is a recommendation given by European Society of Cardiology, where you keep the levels between 120 to 129 systolic and 80, less than 80 diastolic. You can go down up to 70. So 70 to 80 diastolic, 120 to 129 systolic is a recommendation given by the European Society of Cardiology,
Great.
which we always accept.
Absolutely.
And at the same time, I'd like to tell you, people are now trying to see whether we can bring it down less than 120. And trials are there, like aspirin trial, which had conclusively proved that you can bring it down with those people who are experiencing problems like syncope or balancing problems. Such people should be excluded. They should not be given a strict control of blood pressure. Rest of them should be given an opportunity to bring down the systolic blood pressure.
Correct. I'll come back to a little. Wait 1 minute now. In the case of DKD, how much would you like to maintain?
Yes, everything began with the sprint trial in
Yes.
2015. So the sprint trial unfortunately did not include any diabetics, and that is why the spirit and the BP road trials came. So practically maintaining a systolic BP of 120 may be very, very difficult in our population because many of diabetics have autonomic neuropathy. Some of they have severe postural hypotension, may go down and fall in the bathroom, have a fracture neck of femur. So we accept 130 by 80 should be a reasonable target. A much younger patient we would target probably 120, but 130 by 80 is what we look at.
Thank you. Now, SNN, the next automatic question is, what is the preferred drug for diabetes with hypertension?
You need to go for a RAS inhibition. For example, you can use ACE inhibitors or the ARBs. And surprisingly, in our country, all of us, including me, are only in favor of ARBs, not ACI, because.
But whereas Professor Mani says is a pro-drug. So, I mean, yes, good.
Yeah. In fact, if you look at the evidence, almost equal.
Equal, at that
equal. Even reducing the albuminuria, equal. Reducing the cardiovascular outcome, all those, yes.
What about the cost? Which is higher cost? Equal cost.
Almost
It's
equal.
almost
So now that the number of sartans are available, I think it has become easy now for us to procure it from the market.
Okay, so
Very
that's ARB, you have ARB,
Yeah.
you have answered.
ACI or-
Prabhakar, come.
ACI.
Come. I can have to.
ACI or
Prabhakar
ARB.
is the celebrated cardiologist from the Apollo and he's from my institute, JIPMA, and Prabhakar, welcome. Now,
ACI, ARB plus a CCB.
yeah, I'll cut down the
always you-
questions to you now.
Yeah.
I just want to know if you want to give, one you say ARB, how often do you use combinations in
Combination of drugs in hypertension management is a must.
in diabetes?
You should not use a single pill, but you should use a single pill with a combination of drugs, not a single drug. So ACI or ARB plus a CCB will be ideal combination to start with. Add a diuretic if the patient is not responding. Give all three drugs in a single pill. Wait for the things to improve. Fellow is not showing any improvement. Probably mineralocorticoid receptor antagonist will play a role in those
MRA.
patients, even with diabetes. The drug that was recommended by all academic bodies is spironolactone. I think time is not far off to witness that instead of spironolactone, you can always use the newer drug, finerenone, has been recommended. Even those patients with the CKD, where it reduced the albuminuria, but reduced the blood pressure also. Finerenone, the latest study, heart failure study, that is
Yeah,
the
Fine Hearts.
Fine Heart study,
Exactly.
have also shown improvement in the heart failure admission, that everything was cut. Even the cardiovascular risk faced by all these patients with the FF has been shown to have good amount of improvement.
Coming to him.
Yeah.
Now, I think Dr. Fernando, I'll cut down the questions because we have to finish in time. I just want to ask you the confidence trial. How do you think that will change the practice of use of finerenone and SGLT2 in diabetic kidney disease?
The confidence trial definitely has shown great
You got to
improvement.
speak louder because people want to listen to you loud and clear.
Yeah, the only thing is it used only a surrogate endpoint of albuminuria. So it's a very short
And also
period
look at
trial.
hyperkalemia.
Yes, hyperkalemia definitely we
Yes.
have to look when there is a NSMRA involved.
Correct.
Now the confidence trial definitely showed improvement. However, it is a very short period study and looked at only albuminuria as a surrogate endpoint. So they did not show any decline in GFR or dialysis, etc. as a
And
definitive
what are the
endpoints.
implementation? Are you nowadays combining SGLT2 with finerenone?
That is how ideally it should be done. As like in many other drugs that come in new into the market, there is a lot of physician inertia, nephrology inertia,
cost
beginning,
also.
and of course the cost.
Cost.
And then at levels of GFR that are low, NSMRA definitely is, hyperkalemia is definitely a major issue. So we are worried about it.
Correct. I'll just say, please, few rapid fire. I mean, what are the other biomarkers that we are aware, like NGAL? What are the other biomarkers? Are they easily available? Are they being used? Cystatin C.
Yes, cystatin. Now we have cystatin C, but cystatin C again is not in proper bedside use as of now. We are still stuck with creatinine. Though creatinine has got a lot of issues, cystatin C is still expensive, not very well standardized in many laboratories. So still there's an inertia. But if you look at the eGFR, you can calculate it by looking at the cystatin
Still
and
works.
the creatinine combination.
Yeah, it works best, Mohan. I
EGFR.
think that's,
Yeah,
that's
that-
what
I think
easily
that's the most
available and doing.
sensitive.
And the last question. We do not do biopsy in each and every case of our diabetic kidney disease. What is your advice, recommendations to the people, non-nephrologist people taking care of diabetic kidneys, if they cannot refer? And apart from the non-diabetic kidney disease in diabetic, where else you will recommend biopsy?
When you suspect a glomerular disease in addition,
Glomerular
say,
disease, like?
somebody has a diabetic foot, the ulcer gets infected, and suddenly you find this man's creatinine going up rapidly, hypertension worsening, there are RBCs in the urine, RBC casts. So this is a situation.
Glomerular disease, yes.
Yes.
Casts are basic
So
glomerular
in a
disease.
publication that's shortly coming up from our unit, infection-related glomerulonephritis is the commonest glomerulonephritis that happens in diabetes. This is number one. When we have massive proteinuria, somebody has got 10 grams proteinuria,
Yeah.
then we think he's got a paraproteinemia, and not often we have seen. We have seen patients having myeloma, patients having AL amyloidosis. So these are situations. Membranous nephropathy is another glomerular disease that we see in diabetes. So if you ask me indications when I will biopsy a diabetic is when I find the GFR rapidly falling, massive proteinuria, when I find a lot of RBCs in the urine, short duration of diabetes. So these are situations where we look into. And if there are clinical markers, like somebody, the lady having features of lupus or any other systemic illness, rheumatoid arthritis, proteinuria, we would look at a biopsy.
And it changes the management, definitely.
Yes.
Prabhakar, the great. Prabhakar, first question first.
Rem-
And okay.
He already is a bad examiner, sir. He was my examiner. You give him more clues, he's going to ask more questions.
Prabhakar, the first question to you, do you believe, I'm coming to paper and ref, the first question is, do you believe there is an entity called diabetes cardiomyopathy?
There's enough evidence to say yes.
Yes.
There
good.
is enough
That's
evidence.
it. Now, coming to the heart failure in diabetes, PEF and REF, which is more common?
Sir, Indian data has clearly shown only 25% of FPEF. Global data says 50% of FPEF. But in diabetics, the problem is the diabetologists don't screen. Annual screening for NT-proBNP, and if it is more than 125, if you start looking at these patients and look at an echocardiogram, a properly done echocardiogram, because the American Society of Echocardiography has changed its guidelines on how to interpret the echocardiography. Last year it has been changed. So if you do it properly, I'm sure we will also have 40 to 50% HFpEF among our patients. The problem is non-diagnosis.
Good. And if you want to prevent diabetic heart disease and the HHF, hospitalization because of repeated heart failure, what's your advice to the people, internists, diabetes specialists?
Sir, if you're having any patient with heart failure, there are 3 drugs that can be given straight away. One is your SGLT2 inhibitors, clearly 30% reduction.
I'm to ask you, has it become the first drug in heart failure today?
All 4 are the first drugs.
All
The
the 4
foundation
pillars.
drugs. All
And
4
now
should be
you have
started.
added Dr. Fernando's drug also as the 5th pillar.
Finerenone becomes in place of spironolactone in the heart failure with
So
mildly
one-
reduced
one
symptoms.
of the
It's
MRA.
still the 4.
One of the MRA.
One of the MRAs, that's all.
You can
So
describe the
there
army,
are,
all that.
there are 3 drugs that you can start straight away. Depending on the potassium levels, we usually start. Preferably small dose of all 4 drugs within 1 month. That should be the motto. Because a small dose is better than a full dose of one drug. So get all 4
that is
drugs.
very true for diabetes. You know, our discussion. A submaximal dose is the most important
Effective.
therapeutic dose. Absolutely.
So you start giving an ARNI, an SGLT2 inhibitor, MRA, and a beta blocker. And beta blocker, the preferred drug I will tell you is bisoprolol. Because the pharmacokinetics are very less variable, inter-individual variability is less. And we want bisoprolol mainly for heart rate reduction. The best heart rate reduction among the beta blockers is bisoprolol, very clearly. So I think that should be the drug of choice. Once you've added these 4 drugs, there is enough case recently built
what
up
about the,
for very SIGWAT.
what is your comment about carbidiolol?
Sir, carvedilol is a vasodilatory beta blocker. So if you're going at higher doses, over some time your BP starts dropping. And the heart rate reduction, because of the vasodilatation, there is a little bit of a contradictory effect, because when the vasodilatation happens, there will be a reflex tachycardia. So the heart rate reduction is best with bisoprolol. But if your blood pressure is high, please use carvedilol, because that's going to bring down your blood pressure also.
Correct. Now just tell us that how do you prevent this repeated hospitals because of heart failure? And this HHF, hospital heart failure, each time brings down the longevity, brings down more, gets into more problem. There's a huge problem in diabetics.
So this patients, once you're on 4 drug, try to optimize the dose and increase the dose as much as possible. You have some targets. Systolic BP, even 90 to 100 is all right. Try to get your heart rate down to about 60, definitely less than 70, and then your fluid optimization. Self-administered diuretics is the best. So you monitor weight daily and start doing. Once you've had the second hospitalization, if there is a worsening heart failure, clearly there is a case for vericiguat. Vericiguat really helps. And even in those patients who are stable, vericiguat has been recently shown clearly to reduce sudden cardiac death.
Yeah, vericiguat is the latest treatment added to heart failure.
So in your patients with diabetes, push all these 3 drugs. And in the American College of ACC 2026 on 28th to 30th of last month, a paper was published showing that GLP-1 is safe in heart failure with reduced ejection fraction. So if your patient is obese, BMI more than 27, GLP-1 can be given. There's a clear data published on these patients, because so far there is a lot of controversy on that, because there's one paper in endocrinology journal which said that the mortality can be higher. Now that's all out. Now clear data has shown that you can give GLP-1 receptor agonists also.
But
in these
Mohan Select showed it beneficial. The Select trial showed it is beneficial, GLP.
So those are HFpEF trials. All are HFpEF trials. Now I'm talking about heart failure with reduced ejection fraction. HFpEF, it's a proven thing. It's one of the pillars of treatment.
Correct.
And there,
I think it's clear. Sir is telling that for the preserved ejection fraction, it's well known that it is the drug of choice. For the reduced ejection fraction, REV, the last year data, ICC said is a drug. And the latest paper you are quoting said that GLP-1 are also one modality. Yeah, last question. Last question. Now, do you think that diabetologists, not like me, say, my friend, saying that beta blocker will produce hypoglycemia has eclipsed giving optimal beta blockers in the diabetic heart failure management?
so those are days when we were students. It's all gone, sir.
Good answer. Thank you very much, dear friends. Now we will have some rapid fire questions from the audience. Sir, very short questions and equally short answers.
I don't know whether it's a rapid fire or a slow fire. Sir, Dr. Mohan, you said obese, non-obese, but metabolically obese. So if you take a patient who is about 6.3 and has this kind of a combination, will it be right on my part with the HbA1c of 6.3? Can I start this patient on the entire drugs which is available in the market, 3-drug regimen like SGLT2, DPP4 and metformin, lifestyle modification, and giving an advice on drugs, on diet?
Why would you start 3 drugs with somebody on 6.3? See, your target itself is below 7. Below 6.5 is a tight control.
The age is 25, sir. The age is 25. Age is 25.
Whatever the age.
No. Age is 25. Yeah. The waist ratio is about 98.
Start them on diet. Start them on exercise. Start them on low-calorie diet. Ask them to lose weight. Why are you starting them on 3 drugs with 6.3 at 25 years?
I agree, sir. Yeah. We are talking everything in the forum. In reality, how many patients have succeeded, sir? We are talking so many things, but in practice,
but even then, there must be an indication to give the drug.
Sir, I am giving my education, sir. I don't fail to give my education. I am giving the education.
No, not education. Indication.
No, indication. I am telling what is the type you should eat in the morning, afternoon, evening, and night. I give all the advice. In spite of that, see, the diabetes per se is a continuum. It is pre-diabetes. No, it is pre-diabetes. Then you go diabetes. Then you go on. So it is nothing a bother to say. From 6.3 to 6.5, he can escalate in any point of time. 2 days, 3 days, 1 week, 1 month. So that is one.
I think it has been individualized. You have to discuss with the person and individualize it.
Yeah.
Okay.
Sir, when a patient comes to you at the age of 40 and you diagnose with diabetes, and you give all kinds of drugs. At yesteryears, 40 years is something, he was giving sulfonylurea. Now he's 85. Now still he's on some of the drugs, and he's having good. But I want to know whether really is there anything called as beta cell apoptosis, or over a period of time, there's a conversion of alpha cells to beta cells to take over the. Because when you give DPP-4 inhibitors, there should be residual beta cells.
Okay, so it's individualized. Again, it's individual. That is where the precision medicine comes. My grandfather started taking sulfonylurea when he was 44 years old. Till he died at 99, he was on sulfonylurea. My father was only treating him. For 55 years, he was on sulfonylurea. Small dose of Dinyl, half tablet is taking at 99 years, nothing happened to him. So that's an individual thing. No, will I give at 90 years glibenclamide to somebody? I will not give. But he lived like that. That is only drug available. He didn't have hypoglycemia. He lived up to 99 with after Dinyl. He went on all his life. So I think we have to individualize it and then treat. Okay?
Sir, quick three questions, sir. Sir, one is to Prabhakar, sir. Sir, I heard that beta blocker is contraindicated for HFpEF. So, your comments. Second question is, Sir Mohan, sir, you said LDL, especially this coastal parts, it increases by 30% when they consume all these saturated fats. But why the reverse we are not seeing? Most of the studies show only 8 to 9% of reduction in LDL if we can reduce the oil content. That is second question, sir. Narasingan, sir. Third question is, why is there, sir, I will just finish it, just quickly, Edwin. Why is there an inter-individual variation of LDL level? Say, suppose if I just do direct LDL, for a person I am seeing 130 today, but after say 2 years or 1 year, I'm able to see 180, 190. Why is there inter-individual direct LDL variation among individuals? Why is this LDL is varying in the same individual at different point of time, not on statins?
Okay, probably the lipids he should answer, but the question that you're asking is there any evidence that in the places where the consumption of saturated fat is very low, is it low? Yes, there is. Because there are states in India where the LDL level is very low. For example, in Andaman and in Lakshadweep, very high LDL level. They are having 130 LDL and all that they are having. I don't know why. So that's an area nobody would even thought to go and study in Lakshadweep, because we've done it, and the same lab has done everything. So it cannot be wrong. So diet definitely plays a role, but there are also genetic factors which play a role. We know that familial hypercholesterolemia, when you have 190, it is not due to diet at all. It's your familial hypercholesterolemia. So that can be that. You answer the...
Yeah, beta blockers in heart failure with preserved ejection fraction. At a higher heart rate, the LV filling pressures have been shown to be better. And in fact, rapid pacing of these patients has improved symptoms. There is one trial where withdrawal of carvedilol has improved functional capacity. So beta blocker, unless there is a very clear-cut indication, especially microvascular dysfunction, if you've done an angiogram, coronary artery disease, otherwise you preferably avoid beta blockers. It's not one of the pillars for management of heart failure with preserved ejection fraction.
One question come for you. Residual CV risk after giving.
Sir, what's your question, sir?
Yeah, your question.
No, sir, I asked, sir, why is the inter-individual variation of LDL?
Yeah, that is common. I think Dr. Mohan has already answered. No, yeah. BP variability, same way, no, the LDL variability has been recognized. LDL variability has been recognized.
It's more with atorvastatin than rosuvastatin.
No, not on statins at all.
If you're not on statins, inter-individual is going to be multifactorial. Age is going to change also.
I think your friends, many things will come into play. Thank you, dear friends, and it's great round of applause for this. There is one question for SSN, very brief answer. The residual CV risk, even after treating for all your factors of hypertension, and what is it?
Residual risk is commonly encountered in practice. Only thing is about 55 to 70% of the people who receive lipid-lowering drug, particularly the statins, they end up with the residual risk. The residual risk has been identified in many studies. So we need to concentrate on that. It can be a residual lipid-related risk, number one. It can be a residual risk related to inflammation. It can be a residual risk related to thrombosis. It can be a residual risk related to LPA. It can be a residual risk related to diabetes. You need to concentrate on all these things, only then you can achieve the goal.
I think, dear friends, sir, I think we have to...
Yes. Excellent, sir. Excellent.
Thank you, dear friends. I think a big round of applause for the four experts. And, with the limited time available to us, we could take up few questions and we'll discuss the thing that are very important. And see you again soon in many other meeting. And of course, definitely for the 3D next year. Thank you very much. And we'll go.
Thank you so much.